All right, so thank you everyone for watching our little YouTube channel. This is the AMP Student Special Interest Group second chat, and tonight we're talking with Susan Clinton. And we'll just kind of start with the introduction of how you started with your career, what are you doing now, and that whole thing. Go ahead.
Okay. Hello, everyone. I'm Susan Clinton. I have been a physical therapist for probably 30 plus years. I've specialized in orthopedics and women's health for the last 20 years. And I went on a journey about 7 years ago, starting to really specialize into manual therapy along with women's health. I chose the path of going for my Doctor of Science degree at Andrews University because it paired nicely with the North American Institute of Orthopedic Manual Therapy, which was the group that I chose to really pursue fellowship with. I completed everything in 2014, which was kind of skidding in at the last minute, but happy to do so. And now I'm a clinical faculty instructor for NAOMT and also a course instructor for them for specialized courses on topics in women's health.
Perfect. So I want to know, why did you decide to go into manual therapy? Like, how did you see that connection between your women's health practice and knowing that you do obviously manual therapy skills? Why did you decide to kind of go down the fellowship path?
So basically, manual therapy is hands-on. And I've been doing probably different types of manual therapy throughout my career. But I started basically as a generalist, as a physical therapist, and then I spent a lot of time in rehab, a rehab setting. And so everything was very looking at the entire patient and not regionally at a patient. So when I came into women's health, I always looked at them from head to toe rather than just at the pelvis. And we kind of have a little saying in our women's health world, at the hashtag pelvic mafia world, that we want people to put the pelvis back in the body and not look at it separate from the rest of the body. Plus, we want everybody else to know that there is a pelvis in the body and not ignore it. With that in mind, I soon, discovered that a lot of my patients had a lot of difficulties with spinal dysfunction and other orthopedic concerns, as well as other systematic concerns such as cardiovascular, pulmonary, circulatory, lymphatic. And I needed to broaden my horizons a little bit as a physical therapist and spend a little bit more time really searching out and understanding particularly areas of the spine that I felt were going to be very positive and impactful. And one of those areas is the upper cervical joints and their relationship to the trigeminal alarm system, as well as the TMJ, the glottis, how we breathe, how we swallow, how we breath hold, because all of those have incredible impact on increasing intra-abdominal pressure down onto the abdominal canister and into the pelvic floor.
That's a real, I've heard a little bit about that kind of area. Did you kind of just see that in a couple of patients and make the connection yourself, or did you read a lot of articles? Like, how did you figure out that path?
So it's kind of an interesting question. I think what ended up happening, as well as the TMJ, the glottis, how we breathe, how we swallow, how we breath hold, because all of those have incredible impact on abdominal pressure.
Do you have a second page open it?
The abdominal canister and into the pelvic floor.
That's a real, I've heard a little bit about that kind of area. Did you kind of just see that in a couple of patients next to yourself, or did you read a lot of articles? Like, how did you figure out that path?
So, kind of an interesting question. I think what ended up happening, as well as the TMJ.
I'm going to mute mine. Gabrielle, mute yours.
How we breath hold, because all of those have incredible impact.
And then, Susan, if you see a tab on the top, you'll hit the mute button.
And into the pelvic floor. Do you need me to mute mine? That's a real, I've heard a little bit about that kind of area. Did you kind of just see that in a couple of next to yourself, or did you read a lot of articles? Like, how did you figure out that path? So, kind of an interesting question. I think what ended up happening, as well as the TMJ.
Mute mine. Gabrielle, mute yours.
How we breath hold, because all of those have incredible impact.
And then Susan, if you see the tab on the top, you'll hit the mute button. Okay, sorry about that. So I think you two stay muted for a second. Go if one of you guys can go into your internet options and see what's open. I think somebody must have opened up like the live link. Does that make sense? So make sure that the video that we're on is the one that we're recording and that there's not like a second one open somewhere, like on a YouTube channel or something. Okay. And then whenever you're ready, Susan, go ahead and unmute and let's see if that worked.
Are we good?
We're good. Perfect.
Let me just make sure I don't have anything else opened. Okay.
No problem.
I think we're okay now.
Okay, perfect.
Because I think I had joined the call, and then I answered the invitation.
Yep, so absolutely. That's no problem at all.
All the listeners, sorry about that. So I think the question was, how did I decide to take this path? Did I figure it out myself? Did I read articles? What did I do? And I think probably, I said that was an interesting question. To reflect back on one's path is a little bit always interesting. When I first came into women's health, there weren't any courses. There were very few courses. There were very few guidance. We basically, and spotted, spots around the country, tried to figure everything out on our own. And then as we started coming together as a group, we started realizing that, hey, we're all on the same path. For me, my journey was interesting because most of the patients that were handed to me very, very early on were persistent pain patients, pelvic pain patients. And I quickly learned that the symptoms and their complaints were not just in the pelvic region or just in the pelvic floor. Many of them also had combinations of symptoms, such as symptoms consistent with fibromyalgia, migraine headaches, symptoms that also kind of had discogenic type relationships, dermatomal, myotomal reflex changes, and many of them also had swelling and a lot of lymphatic problems as well. So quickly early on, I realized that I was dealing more with systemic type, full body type responses to whatever their dysfunctions were, rather than very localized, pelvic floor dysfunctions. Of course, there are very many localized pelvic floor dysfunctions that never spread into the persistent pain, but those were the patients that I ended up with really early on. So I did a lot of reading on articles. I started looking at I was already treating people with fibromyalgia and chronic fatigue syndrome, which was a big thing back in the 80s and in the 90s. And, so I was already looking at those patients. What it did was it had me go back to my original patients that I was seeing and start asking pelvic health related questions to them and finding out that a lot of these patients were also having urgency, frequency, bowel dysfunction, and a lot of also other types of general urinary and GI dysfunctions as well. So that was kind of the path that took me that way. It was basically my patients led me there rather than me leading myself there. I started paying particularly bigger attention to the upper cervical region because the parasympathetics are housed there. That's like the sacrum and the and the upper cervical areas where we have a lot of parasympathetic input into the spinal cord region, and in the, the sympathetics are more housed in the thorax, where the sympathetic chain gang, and trying to get people to kind of slow down, jet themselves down, de-stress, downtrain, I think is the big buzzword, to get their autonomic nervous system to get into better balance. So, oftentimes could be done with some, changes into their thorax and cervical spine area, which was an area that I previously was not really paying attention to a lot for pelvic pain patients. And so by looking at that and getting movement where maybe movement wasn't happening, or encouraging movement when they were just using a breath holding strategy or a postural strategy, kind of a chronic forward head, raised shoulders, forward, rounded, upper posture, and kind of using that as a strategy typically all the time. By encouraging movement and change in there, I started noticing some changes in their symptomatic behavior as well.
That's really interesting. I've seen, just thinking about that, I've seen a couple of patients that come in with, that kind of forward head posture, kind of pain, central sensitization, almost stuff going on, and I just very briefly dabbled in, some diaphragmatic breathing and some wing arm breathing and stuff like that, but I think it's a very interesting connection to even bring it all the way down to the pelvic floor as well. So how often do you think patients, I guess, are missed in that kind of area where we're not talking about pelvic floor in their orthopedic physical therapy visit or in their neurophysical therapy visit? How often do you think that's being missed, or how do you think that we can kind of bridge the gap between all of those different areas?
Well, I think first of all that patients probably have, it's an underreported problem when you have, and I don't think people know how to ask the questions. A lot of people will ask questions about incontinence, and people may say, I don't really have incontinence, but that doesn't necessarily mean that they don't have pelvic floor dysfunction. It's like, nobody really knows they have hip abductor dysfunction either. They're walking around just fine. We're seeing positive Trendelenburgs or lurches, and, so it kind of becomes an interesting question, how do we screen for it? And I think probably a number of patients are being missed, probably somewhere up to about 75 to 80% are being missed, just because I think what's lacking is understanding how the whole pressure system works, through the trunk. I know core is a big, exciting word, and it's been overused to death, and everybody's got different things that they want to talk about the core. I think one of the most important things for anybody in orthopedic manual therapy to consider is that the core is a very dynamic system. It's not a static system. Abdominal hollowing isn't going to get it. In fact, abdominal gripping is going to make actually the other muscles that work in that particular core system shut down and maybe get inhibited. So if we're constantly gripping with our abdomen, we can't breathe well. The diaphragm can't descend. And if the diaphragm can't descend, then the pelvic floor isn't going to descend on inhalation and ascend on exhalation in a way that it's supposed to work. So it's supposed to be kind of this type of process that goes along, and the other structures are supportive structures maintaining a certain amount of pressure so that the abdominal organs can be healthier and vascularization can occur a little bit better, and respiration can occur at a rate that's going to be a lot more efficient. When we get into those types of dysfunctional patterns, it affects the entire respiratory system, and it affects all of the muscles of the neck and the head as well, because as we have to change our breathing because maybe we're gripping too hard, or maybe our pelvic floor muscles are gripping too hard, or our back extensors are on too much, the head's going to move into a forward position because we have to be able to breathe. And if we can't get good efficient breathing going with our diaphragm, we're going to set our head forward and allow our jaw to relax so that we can actually even almost pant. It's kind of one of those things that begins to contribute to changes in chemistry in our whole system. It moves us into more of an acidotic type response, like getting ready for that flight and fight, even though maybe we're just sitting quietly at our computer. So, so the system can be stressed in that way too. And that, so being able to change that from the inside out rather than the outside in can be, a very powerful tool. Working with orthopedic manual therapy is wonderful because if somebody's developed those strategies, they have developed stiffness, whether it's joint stiffness, true collagen joint stiffness, or if it's muscle holding stiffness, which can be just as powerful as joint collagen stiffness in some respects. Manual therapy, orthopedic manual therapy, using mobilizations and manipulations can really help reset the system a little bit. It gives you that window in so that as you get things to let go, get that reciprocation type response or stop that patterning holding, then you can go in and you can start working with breathing and you can start working with changes. But one of the things I would always say is don't overtrain one muscle of the group. They all need to be working together. They work together like gears, And so if one is overworking, the other gears are not able to work as efficiently. So we have to pull all of that together. And it works very nicely to layer extra, higher level functions over it.
And speaking of, working everything together, I've seen this multiple times, or, I've even been taught, just at the basic level of using, your TA and diaphragm and how to activate the multifidus and all that kind of stuff. Do you have any tips for how to apply that in a more functional way so that people aren't just lying supine, because that's not functional. We don't do anything when we're lying supine like that. So any tips for that? Because that's one thing that I struggle with as a student, is how to take these basic level exercises, basic things that I know are important, to the next level. And even in athletes too, thinking of it that way, how to get these female athletes maybe to apply these during their sport, volleyball, gymnastics, whatever it happens to be.
Those are great questions, and it's always something that everybody grapples with is, how do we get the interventions to really match what we think is happening physiologically? And some of the best things to do, because obviously we may need to lay them supine in order for them to relearn a couple of things. So you can always tell people's primary breathing patterns when you lay them down, because then they're not having to use their diaphragm as a postural control muscle anymore. So always compare that to what they look like in standing and then what they look like laying down. And you'll be able to kind of see what their tendencies are. I don't like to teach a total strategy of either abdomen or thorax. I want it to be balanced. It should be balanced a little bit. So that's the one thing that's really nice about the supine position. But the next thing that actually you can teach people to do, and you can do this in any position, is begin to teach people to breathe in a way that's going to work with them functionally. And so we all know this as people ourselves. If you just take your PT hat off for a minute and think about yourself going to the gym or doing exercise, and when are you taught to exhale? You're taught to exhale on exertion, right? So one of the things that we want to do is we really want to make sure that no breath holding is occurring. We want them to actually be exhaling for exertion. So if we back it down just a little bit, and you've got somebody who's struggling to get out of a chair because either their knees are stiff, or their back is stiff, or their quads are weak, or they're inhibited, and so they're really breath holding to get out of a chair, that's way too much intra-abdominal pressure for that task. We want to be able to breath hold when we're lifting a couch, when it's something extremely heavy. And that's when we want to be able to use that particular strategy, because that makes sense for really supporting everything through the abdominal canister. So one of the things that you can do right away to start getting people to work, once you get these muscles, they kind of understand them a little bit, is to have them bring those muscles gently online with just a very easy exhale, or an exhale through like a straw or pursed lips, just a little bit. Not a strong, resisted exhale, but a very easy one. And that requires them to relax their throat, to relax their diaphragm somewhat, and to actually begin to work that diaphragm a little bit more eccentrically. And that's really important for controlled breathing. Then we give them the clue, and a lot of this information comes from Julie Wiebe, PT. You can find her on the internet and on Facebook and Twitter. But she calls it blow as you go, or blow before you go. I just tell people that we really want to move, or we really want that breath out happening as they move. So I'll give them lots of different cues. We'll either do an easy breath out. If they're having trouble with that, or they cannot really tune into the fact that they're breath holding with like getting out of bed or getting up out of a chair, I'll teach them to actually talk while they do it and listen to the tone of their voice, because if they start talking, then we know they're closing up their throat. They start using some of those strategies, it makes a huge difference for how they're functioning, and they can hear that, and that's really important. So, and then as you take that up to athletes, it's very easy. You've got to tell them that I never take athletes out of what they're doing, because as soon as I do, I've become irrelevant. What I need to do is help them have better performance enhancement, unless, of course, there's an injury that requires rest and requires, certain things. But if it's somebody who's really, just having pelvic floor dysfunction, or maybe some leaking with their activity, I may change that activity for a bit till we can get that pelvic floor and the rest of that core system up and working a lot more dynamically. So I may change what they're doing with their running. Maybe they're going to be running in the pool for a while, or they'll keep their cardiovascular up on a bike or some other things while they get that other system trained up there. Because oftentimes it could be that they either have a poor coordination control of their canister, or it could be offline because they've got a lot of load transfer problems. So they've got some stiffness in their toe, they've got some stiffness in their knee, some stiffness in their hip, and it's causing load transfer problems that needs to also be addressed as we're addressing this whole system.
Great. Thanks so much for answering that. I'm going to stop stealing you and let Gabrielle ask you some questions now.
Okay.
So as a student, I guess I'm curious for your insight into knowing that you're an orthopedic specialist, a women's health specialist, and so going into your fellowship training, what were you kind of looking to get out of it? And or were there things that you did get out of it, kind of looking back on it, that really kind of differentiated from things that you had received with other forms of training that you felt like really made an impact on how you treated patients?
Let's see how I can answer that. So I went on this journey. I started as working on my Doctor of Science degree, which was something that I had wanted to do. When I went to PT school, it was only a Bachelor of Science in Physical Therapy, and then in the 90s I had to get my Master's of Health Science to keep up with the MPTs in order to keep teaching in a physical therapy program. And, as the 2000s came along, I needed to do something a little bit different. I wasn't real sure if I was going academic or clinical or where I was going to be, but a Doctor of Science program was something I wanted to do. So I had met Jim Meadows, a while back, and I actually went and took another course with him through a different stream. I was looking at their Doctor of Science program, and he was doing some guest teaching in it, and he sat down with me and we talked, and he was very clear. He said, I told him the things that I was interested in, that I wasn't real sure where my approach was going to be, but I really wanted to, head towards the North American Institute of Manual Therapy because their approach is very eclectic. They don't teach one way. They want people to come in from all different kinds of processes, life experiences, because they want the system to be challenged all the time. And so he was very pragmatic with me and said, this is where you belong, but this is not the program for you. Andrews is going to be where you need to be. And right away, one of my the two NAOMT instructors that I had through my coursework were Bill Timms out of Oregon. Excuse me. Too much talking. And Earl Petman, who's from Canada. And Earl is one of the founders of NAOMT. So I started my journey that way with those guys, and right away started, working with, well, how is this going to apply to this type of condition and to this type of condition? And quite frankly, it's been like the pain science group. They've never considered pelvic pain. They considered chronic regional pain syndrome or amputation with, pain science in the beginning, but they never considered chronic pelvic pain. So looking at and challenging, their views on how to stabilize the spine. And maybe we don't need to stabilize it, we need to coordinate it. And being able to work through, those types of questions and those types of comments with people who really didn't have much of a better handle on it than I did, but having a group willing to open up their eyes and do that with me as I went on the journey was one of the reasons that I decided into my my Doctor of Science program that I really did want to pursue the fellowship program. And that's why I did it, so that I could bring, some more pieces of this to NAOMT. And that's why I'm starting to, we're actually opening up some women's health courses within the NAOMT curriculum so that we can deal with that very thing that Melissa was asking. how many of these patients are we missing, so that people aren't afraid to treat the pregnant lady, and they're not afraid to treat, you know, some of these other dysfunctions and ask about them, so that they feel a whole lot more comfortable in integrating that information.
Great. So I guess kind of to close out a little bit, I was hoping that you could weigh in on something that I've kind of heard some mixed opinions on, and I think maybe for students that are tuning in, they might be in a similar situation. I've heard some people that you talk to that have pursued fellowships have told me, man, I really wish I would have done it like 5 or 10 years earlier, and then I could have, you know, had all that knowledge to work with the patients all along. And then some other people that I've talked to have mentioned that they were really glad having that clinical experience going into the fellowship. That really allowed them to kind of put everything together and really hit their stride with just their own clinical practice. So, you know, as students, we're always thinking about what we want to do with our career and different choices and how we want things to play out. I guess just from your own personal experience, do you have any advice or want to weigh in with one side or the other in that?
So it's kind of a catch-22 conundrum, isn't it? You know, you're kind of darned if you do and darned if you don't. I know that as a student, and I've been around many students for many years because I've been an adjunct and a professor in PT schools for a good piece of my career. And I know that the last thing a student wants to hear is you have to tough it out till you get the experience. And I know it's the most frustrating thing in the entire world. But with that said, there is a certain amount of experience that's helpful. So one of the things, rather than, you know, because I know that some people are more prepared than other people. Some programs prepare students a little bit better along the lines of orthopedics and manual therapy than other schools. So in some places there may be a little catching up to do. And other places, they may be a little bit more prepared, whether they're going through residency or whatever it is, or how, you know, kind of their continuing education path they've decided to put themselves on. The one thing that I will say, whether you go earlier or later, is pick a path that's not easy. I know we all want it yesterday, and we all want that 1 year to manual certification and, you know, 6 more months and I've got my FAA OMPT. And it sounds really good, but what really, really, really gets missed in a track like that is that experience. And so there are so many wonderful tracks out there that can lead you towards that ultimate goal if that's what you wish, but will allow you to develop as you do it. So I never counsel anybody to go right into a fellowship program. I counsel them to take a stream of classes, whether it be level 1, level 2, level 3 through NAOMT, or, you know, there's many other, you know, equally wonderful programs, St. Augustine. I mean, you can name off, 40 of them if we wanted to. But the idea is the programs that really don't want you to come in until you're at a certain level, and they really are wanting you to bring in, you know, some other professional education with you as you get there. So residency can do part of it. You know, having an OCS maybe will be a better, faster track in the beginning. But quite frankly, I think that the fellowship piece should take just a little bit more time, because what you know, when you consider what a fellow is, it's somebody who's really put in the time, the experience, and it's a program that's rigorous enough that is requiring some, not only being a good consumer of the literature, but actually contributing to the body of knowledge, whether it's clinical research or a systematic review or pulling together, you know, some other intervention type case series, you know, things that are very, very important. And that takes a little bit more of professional experience and professional practice to get there. When that happens, then there's a lot, you bring both worlds together just a little bit better. So, you know, it's not a clear path for a lot of people. And I would just tell people, if they feel like that they need more, to, you know, be patient and get into some level 1 courses and kind of experiment a little bit and listen and feel what's going to be right for you, because not every program is going to be right for every person. Like I said, some students are, you know, are much better prepared in certain avenues than others, and we know that there is a little bit of a difference across PT schools. So and I think just that careful reflection that you need to do is like, what am I missing? What do I want? and what kinds of how am I going to get there. And I think putting yourself on that journey is a very viable, worthy journey to do. The good thing about a fellowship program is that it doesn't really matter when in your life you do it. If you're comfortable and you're ready to do it, then you're ready to do it. If you're not, and you've got other things that are that are requiring your attention right away, that's fine too. There's never a bad thing, and in fact, there's a lot of people who are choosing to go through fellowships much later in life. I'm one of them. It just turned out that way for me. It wasn't like I set off on this journey, explicitly to do. It was something that just kind of unfolded in my path as I was going down the road. So be open to those things. And the one thing I will say about orthopedic manual therapy for students who are considering this and looking at this, find a program that's going to be very holistically based. Because an orthopedic manual therapist, the best thing about finding really good ones is they look at the entire person, and they may have to concentrate on a region, but they look at its implications across the entire body and through function. And I think that's what makes the journey so much more fun as a PT, because you really are, changing how people function and move in a little bit different way.
Great.
Mm-hmm.
Thank you so much, Susan, for everything. This was a great talk, and this will be posted live on YouTube right now as we're speaking. So Thank you again for everything, Susan, and thanks, Gabrielle, for asking questions with me. And thank you for all our viewers for watching this again. Have a good night, everyone.
Good night.